Hello, and welcome to ADEX in Conversation special series addressing COVID-19. I'm your series moderator, Dr. Jill Harrington, coming to you from our nation's capital, the Washington, D.C. area. Joining me here today in conversation is also Mr. Isaiah Allen, Executive Director of ADEC from Minneapolis, Minnesota. Today we welcome members and colleagues at ADEC from around the world, whose panel discussion will give us an international perspective about the impact of COVID-19 on dying, death, and bereavement. Joining me here today from many time zones are Christopher Hall. Chris Hall is a psychologist, past president of ADEC, and chief executive officer of the Australian Centre for Grief and Bereavement. Dr. Carl Becker from Kote University in Japan. Dr. Becker is specially appointed professor of policy science at the Medical School of Kote University, where his research is focused on medical ethics at the end of life, psychosocial support for terminal patients, and burnout of medical staff. Dr. Andy Ho, fellow in thanatology and associate professor of psychology, School of Social Sciences, joint honorary associate professor, Lee Chong Chien School of Medicine, and Nanyang Technical University in Singapore. Dr. Darcy Harris, who's also a fellow in thanatology, an associate professor and thanatology coordinator at King's University College at Western University, London, Ontario, Canada. And then finally, we have Dr. Stephen Connor. Dr. Connor is the executive director of the Worldwide Hospice Palliative Care Alliance that has over 350 organizational members in over 100 countries. Dr. Connor has worked in palliative care continuously for the past 44 years as a researcher, licensed clinical health psychologist, consultant, author, educator, advocate, and executive. We welcome you all here today from around the world and want to thank you for joining us. Dr. Connor, I wanted to actually start with you this morning and ask you a little bit, because your focus is really going to be more end-of-life care and palliative care. I wanted to ask you, how is it that palliative care is appropriate for an infectious disease like COVID? I mean, many people think that palliative care is for chronic health conditions or when people are dying of chronic health conditions like cancer, COPD, heart disease, and so forth. Can you share with us a little bit about the appropriateness for this disease?
Well, thank you, Jill and colleagues. It's good to be with you today to have this conversation. I think we can probably learn quite a bit from our colleagues around the world on how to cope with this new reality that I think that we're all facing. The people who need palliative care, the notion about who needs palliative care has been redefined recently through a report from the Lancet Commission on Palliative Care and Pain Relief. We, have historically thought of palliative care as for cancer and some other chronic conditions, but the reality is that that anyone who's experiencing severe health-related suffering is appropriate for palliative care, and that includes some infectious diseases. I mean, we've always been since the beginning of the HIV pandemic, we have had infectious communicable disease patients. We also have patients with TB that need palliative care. These are neglected areas of palliative care development, but the Lancet Commission report shone a light on this issue. So we really have kind of two populations now that we're dealing with. One is those patients we typically have been caring for who have palliative care needs, and now we have patients with COVID-19. And sometimes we have traditional palliative care patients who also have COVID-19. So we've really been facing some pretty significant challenges in caring for them.
What are you seeing as the major barriers to delivering palliative care during the COVID pandemic?
Well, we're getting reports from our members and colleagues around the world about real serious impairment in ability to deliver palliative care. And I want to stress that palliative care is a critical part of the COVID-19 response. It's not something off on the side. It is central to actually the care of these patients. And I think at least in high-income countries, the healthcare systems are beginning to recognize that, our help with managing severe symptoms, our help with improving communication about conditions of the patients, our help with the grief that comes after the illness. All of that is really, those are central kinds of care that these patients need, that we actually are used to doing. I mean, having these difficult conversations, being able to manage breathlessness, all those things are part of our body of knowledge and skill set. I think, and people are calling on palliative care more and more. But the barriers we're hearing, for instance, in countries like Malaysia and Bangladesh, the police have set up roadblocks. So palliative care workers can't get to the homes of patients without great difficulty because they have to stop and show their credentials. And sometimes in Bangladesh, we have 2 sites where we're testing models of palliative care, and there is a major roadblock between Dhaka and the Narragansett city where we work. So people literally can't get there. We have some staff who live in that community who are carrying on, but it's been quite difficult. We're hearing a lot about palliative care units being taken over and the palliative care patients being sent home or kicked out to make room for COVID patients. We have problems with lack of food and access to food. In India and Kerala, they're having a serious problem with suicides of alcoholics who can't get access to alcohol and are going into DTs and in some cases killing themselves. But there's a huge problem with lack of personal protective equipment, and we really can't go see our patients without protective equipment because we could become vectors then and start to spread it among other patients. So we've, kind of early on, against the advice of WHO, have been, advising people when there are no protective equipment available to make their own and to be creative about doing that using vacuum bag filter, HEPA filters and things like that. We are having problems in the UK. I mean, there also are patients in the hospices that have COVID now. And there's a triage system that has been developed, which has real significant ethical implications for us. Basically, if you're a terminally ill patient, you're not going to be able to access critical care, period, in the UK. And there's, basically anyone, whether they're a palliative care condition or not, are being sort of triaged to what's called end-of-life care, which is essentially palliative care. And in the U.S., the ward in Mount Sinai, I mean, it was taken over by COVID, and they're having to turn all those rooms into COVID treatment rooms with positive pressure flow. And the patients are, what's happening is they're basically sending patients home with cancer and other conditions and saying, sorry, we can't take care of you, go home, and without a proper follow-up. So it's a pretty serious problem. We are getting a lot of requests for more consults for palliative care coming in at the same time.
Now, palliative care has often been described as high touch, low tech. And how can hospice and palliative care providers deliver compassionate care if they aren't able to physically interact with their patients and do more virtually? I mean, someone who had 2 parents die in hospice and who both got palliative care, I understand this quite fully, and that power of touch and being close to patients. How would you say that we're able to deliver that now?
Well, even before COVID came on the scene, we were having to take a serious look at to what extent we can do, what is the dosing of virtual versus in-person care. You can't really do palliative care entirely online or virtually, but a large part of our work could be done virtually. So, and we've had to try to come up with ways of making this kind of experience that we're having on Zoom something that's not just intellectual or thought process, but helping people with their self-care, doing meditation, doing counseling essentially online with people, And I think it's a serious challenge because I mean a lot of like in the hospice I work with here in Washington D.C. area we have the social workers and chaplains are no longer and volunteers are no longer visiting the homes. Only the nurses and physicians with PPE, so they're doing all of it online, and it's a serious limitation. It's not easy.
Hmm. What lessons can palliative care providers learn from the HIV pandemic and the Ebola crisis, you think?
Yeah, I mean, we did have a sort of a prelude to this with the Ebola crisis in Sierra Leone. We had supported our colleagues at the Shepherd Hospice there to be involved, particularly in the grief issues for families afterwards. And some of the hospice staff died of Ebola there. But again, you know, it is really important that people understand that palliative care is an essential component of the COVID response, that it's really our skill set that is needed desperately for these situations. We need to listen to the people who are affected. What are their needs? Make sure we're paying attention to those. They're different needs than we're oftentimes used to dealing with. We have to have personal protective equipment and the funding necessary to train people. You know, we would be doing much better if we followed the rules that you need to train every health professional that comes out of university or medical school or nursing college in the basics of palliative care. We need to be integrating that into the care. We are seeing the almost spontaneous formation of what we could call compassionate community response, which is an interesting development. We've been promoting that idea anyway as part of palliative care development, but communities are really coming together. I mean, we work in some slum communities, for instance, and which is quite a dangerous setting to deliver palliative care from a infectious disease standpoint. And people are just remarkable at how much they're able to care for each other. We're seeing shortages of essential medicines, and it's a critical thing that we have morphine available for breathlessness, and we have other essential medicines that we need to properly care for people, and relaxing some of the restrictions that we've seen as a result of the opioid crisis here in the United States. We need to deal with some of these ethical dilemmas that we're facing, and really it's pointing up the weakness of healthcare systems and the importance of having universal health coverage in every country, which is a goal of the United Nations Sustainable Development Goals.
So just a question of mine that I thought maybe you could share with the audience, because you know there may be patients on COVID-19 that are receiving palliative care. Can you kind of debunk the myth a little bit about what palliative care is? People essentially think it's only for those who are dying.
Yeah.
Which is a myth.
Yeah, absolutely. I mean, in the Lancet Commission report, we basically identified that there were more people who we call non-decedents who need palliative care than those who die in a given year. Palliative care needs start, you know, sometimes several years before a patient dies. Some patients, you know, in the case of COVID, you know, they may recover and then not need palliative care. Other hemorrhagic fevers also are patients, and those with severe injuries sometimes will recover, but need palliative care. It's really about the suffering. It's really about the degree of suffering that people are experiencing that we bring our skill set to bear. Yeah.
And so it would be important for the healthcare workers, but the families to ask those conversations, because it doesn't exactly mean because someone may need palliative care that they are in the midst of dying.
Yeah, I mean, WHO as a definition of palliative care has always stressed that palliative care should start at the time of diagnosis of an illness or early on in the illness. And, you know, we carry on with people, and sometimes their needs increase or decrease. It's certainly not just end of life care. And that's a thing that's been difficult for us to sort of re-educate people about, or, you know, get over the stigma of the D word, as we call it, the death word.
Because it could be frightening to people who don't understand the difference.
Yeah. Well, oh God, you're bringing palliative care in. I must be in bad shape.
Yeah.
But actually, yeah, we hope a lot of these patients with COVID will pull through. We don't want people to die. We have to die. You know, we want it to be a good death as much as possible.
So sort of in closing, how can we help palliative care and healthcare workers to handle their own grief when they're seeing so much death in such a short period of time? It almost reminds me like a war zone where there's so much death all at once and our healthcare workers are so overloaded.
Well, it's really hard for the healthcare system. They're not used to seeing this much death. We at least, I mean, in palliative care and hospice care, we are, we understand patients are going to die. We don't, and I think that the secret to this, one of my colleagues, Professor Dale Larson at Santa Clara University, has coined this idea of balanced empathy, that we have to develop the capacity to help people. We can't be cold professionals, but we can't be over involved either in their, whether they live or die, and to be able to be there, but not lose something if the patient dies, or feel that we're harmed in some way by their death. That it's more about how they pass and die, and whether we make that a less difficult situation for them. This is especially hard even for palliative care workers, because people are dying alone. They're not able to resolve those things that give us meaning in our work, are being able to witness patients and assist patients in resolving the whatever unfinished business they have in their life. And that's not it's much harder to do in this situation. Things happen really quickly. Patients deteriorate very quickly, and there's no time to do things, and families aren't allowed to visit. So it makes it more difficult than the typical hospice patient. But at least we have those who successfully survive working in palliative care are able to navigate that, I think, a little bit better than the rest of the healthcare system.
Sounds as if, too, it kind of is not the model of training necessarily everyone's had, in terms of not being able to be there by bedside or help out with the families and see that unfinished business. So
yeah, it's hard days. It's also bringing people closer together. I think, my experience, we're seeing more compassion, more it's bringing out empathy that is an essential part of human nature. I think that when we're all separated, it makes it more important to bring those positive qualities out, at least in many of us.
Would you say to all those health workers that peer support, peer debriefing, maybe even their own mental health care through this and after this is something that's important to keep up with their own emotional well-being and mental fitness?
Yeah, I mean, part of successfully working in death, dying, and bereavement is being able to take care of yourself, to do self-care. And we can't just do that by ourselves. I mean, I think we have to take care of each other. We have our staff meeting on Zoom every Monday, and we start off the meeting by doing a check-in with everybody. How's everybody doing it? Having time to let people, talk about what's difficult in their life right now, not just business. And I think that's true for frontline workers as well. Okay.
Dr. Stephen Connor, thank you so much for sharing with us just a wealth of information from around the world about what's going on here, and all the work you are all doing in palliative care and hospice around the world. I want to thank you so much for joining us here today.
You're very welcome, Jill.
I want to turn now to Chris Hall in Australia, who's going to talk a little bit about maybe giving us a snapshot of the impact of coronavirus within Australia.
Thanks, Jill. It's lovely to be with you and many of the familiar colleagues around in this virtual room. The picture we're seeing in Australia is starkly different from what we're seeing in the UK, Europe, and certainly in the USA. If this will work, yes, you can see here that we've had, actually as of today, 60 deaths as a result of COVID-19, just over 6,000 cases identified, and just over 3,000 people who have recovered. 65% of people who've acquired COVID-19 have come from overseas. And in fact, there are 18 deaths that came from a single cruise ship. And so currently we're actually seeing many clients who are also engaged in potential class actions against cruise lines. So there's, for many bereaved people, a combination of both legal difficulties and as well as their own bereavement. Our borders were closed reasonably early in early March, and everybody who arrives back in the country for some time has had mandatory 14 days of isolation. It's important, I think, to remember that COVID came on the back of some pretty horrendous bushfires in Australia in December and January that saw 34 deaths. So there is certainly, for that cohort of bereaved people, a sense, I think, of displacement. And I think that applies in general to other people who are experiencing non-COVID related deaths as well at the present time. So I think the kind of damage that we're seeing is also kind of a social and economic damage. It's the tension between the kind of the health and economic priorities. So we have nearly 4 million Australians unemployed at the moment. We've had a shutdown to a large extent of our economy. There's been additional funding for mental health services, particularly around family violence services, in terms of the impact of social isolation. And I think, as we all would recognise, that those intangible losses that we all experience of this loss of predictability, this sense of safety. Certainly for us, there have been issues around funeral attendance and the frustrations around even questions of being present at the time of death. There have certainly been complicating factors for many bereaved people. Certainly, I think one of the challenges of Australia has always been its geography. The country is as large as the US. The US, of course, has 14 times the population of Australia. So many of the ways we've been responding to overcoming distance, such as the use of telehealth and telephone support, I think we've kind of been well placed in that we've been operating those services for now a number of years. And so it's been simply a case of kind of ramping up. And perhaps there's also been some positives there as well, in that it's really required us to move into looking at online bereavement support groups rather than just individual work. So in many ways, the challenge now, particularly with the flattening of the curve as we've seen in Australia, is this tension around kind of economic drivers and the kind of the social and economic impact and damage that we've seen. And I'm sure we'll continue to see for many years. Effectively, at the moment, the government is funding employers to keep their staff on. So there's a significant economic rescue package that's been put together. How sustainable that is and how long that can remain, I guess, is a question for both economics and also kind of health impacts. In terms of the way we've... Sorry, Jill, go ahead.
No, I'm saying you bring up such a important point about, how the Australian bushfires, which were extremely significant this past fall, and now you're going through the COVID-19 crisis. I'm just so interested in how that's affected people in Australia.
Well, I think, to borrow from Ken's work of the idea of being self-disenfranchised, the sense of that there's people who are experiencing these horrendous bereavements with all their complications, that my loss seems so trivial in a sense. And so I think it certainly impacts upon help-seeking behaviour and people's reluctance perhaps to seek out support, whereas they may have ordinarily. And so, I think in terms of the way we deliver services is profoundly impacted. We monitor clients throughout our engagement with them at every session, and we can see the impact of the lack of social support, social connectedness in their own experience of bereavement. And so I think that certainly is we all know about the benefits of social support as buffering effects, and not everybody has the access or the facility or the economic power to enlist in web-based support. And I think there's still a lot of reluctance, both on the part of clients and also of clinicians, of engaging in delivering clinical services, which is mediated in part by technology. And so I think it's I think driven many clinicians and also encouraged many clients to perhaps move into seeking that kind of support where perhaps they may not have in the past.
Now, your center, Chris, the Australian Centre for Grief and Bereavement, is largely funded by your government. Can you kind of share with us a little bit how your organization has responded to this pandemic?
Sure. Well, I think the first area is really about information and some clarity, and we identified a number of themes and issues that came up, and like many organisations developed fact sheets, these on the idea of living in uncertain times, dealing with the anxiety, the lack of predictability, the lack of this sense of safety, one around funeral support and physical distancing, again picking up on that important work about making distinctions between physical and social distancing, social support during bereavement, how important that is, and also about supporting children during times of COVID-19. I think we were certainly getting lots of inquiries from public hospitals about the management of bereavement in terms of these particular types of death. We certainly did work with the funeral industry around concerns about restrictions in terms of 10 mourners being present at a funeral, and thinking creatively about some other ways that those important rituals might be facilitated. Again, in Australia, less a concern for us, but the idea of 5 people being present at a wedding. So these are significant ruptures for people. My daughter was to be married in a few months' time. That's one that I became certainly acutely aware of. So I think it's those concerns that people's sense of entitlement, of being able to access support. We've received very few clients. In fact, most of our clients have been referred to us through legal firms. And so, we've not seen at this stage a significant influx of clients, but we certainly seen the impacts of COVID-19 in terms of other bereaved people and the general anxiety that everybody feels, clinicians as well. And like Stephen, working with a fantastic group of 25 clinicians and staff, being mindful that they too are impacted. Schools are closed. They're often having to deal with their own children being at home. These are certainly unusual times for everybody.
So this idea of grief leadership has emerged through some of these conversations, and it seems like in a very short period of time, you all pulled together a lot of information really fast. Can you just address to me how that decision was, that kind of call to action was made in your organization?
Part of that came from government. Government were identifying themes, particularly in aged care settings, that we wanted to respond to. They were identifying issues for staff in aged care facilities. We certainly heard from clients about what their concerns were. So that in a sense laid out the map of what those areas might do. It also saw us ramp up things that we've been doing for some time. So, for 2 years we've been running a telehealth program, and that has been a very solid base for us to work from. It's certainly not true that if we build it, they will come. I think it's really important that, and one of the things we found very useful is to have clients who are happy to in a sense provide testimonials about the value and the effectiveness of telehealth, and that's a very important thing. And also trying to reduce the burden for people to access that technology has been important. We also recognize that many people self-manage their bereavement experience well, so we've certainly ramped up the promotion of an app that we've developed. It's available in Australia, the US and the UK, called My Grief. It uses the same clinical measures that we use and then provides tailored strategies and suggestions for bereaved people, but also provides strategies and suggestions for those who are supporting somebody who's bereaved. So I think there's certainly a lot we can do around helping people self-manage, also recognising that many people who are highly distressed simply won't present to health services or to counselling. And so what are the ways we can kind of impact upon that kind of help-seeking behaviour where individuals feel that their pain is overwhelming, or perhaps feel pessimistic that will counselling or support make any difference?
As a leader of your organization, how have you sort of been helping your workers as well too to kind of manage with some of this, the stress they're feeling?
Well, I think it's really important to connect more frequently. I was saying to somebody recently, I probably feel in a sense more connected to my staff now than I would when we were sharing an office. I'm much more mindful about that. So every Friday afternoon at 4:30, we have virtual drinks. I run bingo, and we do trivia, and we have a lot of fun together. And so sharing fun, sharing enjoyment, and also recognizing that, that they as individuals are experiencing their own anxiety, their own bereavement. And so I think providing opportunities for us to meet as a whole group or as teams is a really powerful thing, and to share humor and to do those, kind of dopey things that inject a sense of lightness into our work.
Stressful times can really bring people a lot closer.
Yeah, I think that's important to recognise that it's not all bad, and I don't want to preemptively move to, issues of post-traumatic growth, but I think in many ways we will see longer-term changes to the way we support people, I think. I think we'll see a greater embracing of technology, and I think that sense of the importance of connectedness is something that's been highlighted. So, we're a well-resourced, reasonably affluent, country that's been kind of well-resourced and made a decision to very quickly, the benefits of being an island nation have shut down borders. And so, it's still in many ways early days. But there is this overwhelming, sense of anxiety, this invisible threat. And I think there are many losses that we just haven't been able to label yet. It's such an unfolding dynamic experience. So I think we need to be kind of, mindful and wary of those developments in the future.
My last question, just real briefly, how do you think this pandemic's what kind of effect do you think it's gonna have on the delivery of your grief and bereavement services in the long term?
Yeah, look, of course, I think the impacts will vary enormously depending on what countries people are in. I think in Australia, one of the things we recognise with the bushfires, for example, is that people who didn't lose a family member didn't see themselves as grieving or bereaved. And so in many ways, they were the most vulnerable group. The person who knew somebody in their community but didn't identify themselves as bereaved. So I think there'll be a number of ways we actually see bereavement, that we're not talking about kin or family-based relationships. Secondly, I think there'll be a much greater recognition, I think, of non-death losses. I think in many of the ways the financial, social and economic impacts that we're yet to see is the kind of the second wave of kind of injury. And I think it also will change the way we perhaps think about social support. I think I've seen some really creative ways that people have come together in spite of the difficulties of physical distancing. And so, perhaps the sense of being kind of more connected may be something that arises as well. It'll be interesting to see what those changes are.
Well, Chris, I want to thank you so much for being with us here today on the panel and just sharing all this very well organized and thought through information coming to us from Australia. Just thank you so much, and be well and be safe.
Thanks, Jill. My pleasure. Thank you. You too.
And with that, I'm going to turn to Dr. Carl Becker, who's coming to us from Kobe, Japan. Dr. Becker, how could COVID set back death education and counseling, you think, by a whole century?
Well, Jill, 100 years ago, Sigmund Freud proposed we should ignore bereavement and forego mourning. And the reason the Western world followed Freud for almost a century was not his great wisdom, but because the Great War and the Spanish flu had cost so many lives in the 19 teens that people didn't want to go back into that funk. They just wanted to go back to normal and get over all those deaths. And the over-publicized wave of COVID death threatens to numb and deafen us all, to make us just want to forget about it instead of facing our own mortality.
Very interesting. You're supposed to just, let go of the deceased and kind of get to a level of pre-loss functioning, right?
Well, looking at the news every day, everything is COVID. And at a certain point, you get saturated and say, how much more of this do I have to take? So our natural tendency is to want to distance ourselves from this reality.
Because as you point out, during other past pandemics, we didn't have such widespread information to tell us what was going on around the world. So people still functioned within typhoid and they functioned within the Spanish flu. So by overemphasizing the COVID death, can it be counterproductive for us, do you think?
Absolutely. As Stephen alluded, I think it's unfair in a way to the millions who are dying from cancer, cardiovascular, COPD, not to mention tragic sudden deaths like accidents, suicides, and even cerebral aneurysms, highlighting the minority of COVID deaths. And they still are a small minority compared to what everybody else is dying from. Downplays the majority of other deaths and sudden deaths. And overplaying COVID can stigmatize former carriers, even though they're now immune, or Asians blamed for originating it. We've seen cases where Asians have been stabbed and beaten in America because somehow they're associated with the bad guys. This is just not acceptable, much less rational.
Do you think COVID makes society face death and mortality more than other disasters?
Because of its self-isolation, yes. Ernest Becker proposed that our daily work routines and purposes are what he called mortality projects, designed to help us forget and deny our mortality. And when self-isolation disrupts our daily, not to say petty work routines and purposes, and we must confront simply existing with ourselves, with our families, with our meals and houses, we risk a glimpse not only of our own mortality, but also the emptiness of much of what we're doing. Our ambiguous loss of the abilities to plan and predict and project, and of our social connections and personal freedoms, as well as of our jobs and financial securities, threatens our sense of meaning and purpose in life a lot more than other ways of dying have.
Well, a lot of disasters sometimes only happen in one place geographically, but this is now a worldwide disaster, natural disaster, almost kind of moving over the earth like a tsunami, like a global tsunami. So it is a little bit different, you would say, right? You think?
Yes, and the global aspect of it is a two-edged sword. It should teach us not only that we can get infected from other countries, but that we depend on other countries for protective gear and ventilators and a whole range of other opioids, whereas the knee-jerk reaction of some states and countries is to close in and say, me first, and I don't want to cooperate. And this is really counterproductive. This is the time we should be getting over this rather than playing into it.
So from an ethical standpoint, what do you think some of the social injustices does COVID particularly expose?
Thank you for asking. After all, I'm an ethicist by training. The big one right off the tap is poverty. Amartya Sen recently pointed out that disease kills people, but poverty kills many more people. Thousands die every day in America, not to mention Asia, without adequate income or medical treatment. And the more people who don't have a home wherein to self-isolate or have to go to work every day just because they won't eat if they don't work, the longer this virus is going to flourish. So there's an economic ethical issue here. There's also an ethical issue on loneliness and despair of self-isolation. Studies in Scotland, Australia, and elsewhere have shown that loneliness is a major mortality factor, a comorbidity factor. And the loneliness occasioned for many people by self-isolating may have a morbidity factor, mortality factor, not next month, but a year or 3 years hence. It'll be hard to tease out of the data, but it's not going away when COVID goes away. For other ethical dilemmas, look at the difference between, for example, South Korea, Taiwan, and Germany. Have done very well because they have monitored with GPS systems where everyone is. And whenever somebody proves positive, they can immediately backtrack the data and find who else that person has contacted and isolate them as well, or test them as well. Whereas in America, there's a knee-jerk rejection of this, and Japan is on the fence trying to decide whether to go the South Korean way or the American way. America, Spain, and Italy, which have not tested nor monitored their populations, have paid big prices in death tolls. So maybe this is the time to put society ahead of individual self-interest or privacy preferences. Also, Stephen alluded to the triage, poly kind of issues. In my hospital, we do more liver transplants than anywhere else in the world, probably. And if we have only one liver to donate, everyone in the hospital, even potential recipients, will agree it should go to a young person rather than to an octogenarian. But we're not following that same ethical logic when it comes to COVID. We're putting a lot of medical resources into people who are going to die in a year or two anyway from other factors. Now, I alone am in no position to make those difficult ethical decisions, but we need to think not only how many numbers of lives are we saving, but are those lives that we're saving going to last 2 more years or 50 more years? Because there is a difference there. A final ethical danger may be in wanting to get back to normal, whatever normal is. We've learned much from COVID about inequality, about healthcare and disaster preparation, even that we can reduce pollution by a whole lot less travel and commuting. Diseases should teach us to live healthier lifestyles. If I get sick, rather than just taking a pill and getting better tomorrow and forgetting that I ever got sick, I should learn that maybe I shouldn't be staying up so late at night or drinking so much or partying so much, and balance my lifestyle so I don't get sick from the same thing again. Similarly, if the world gets sick from COVID, let's hope we learn not only better disaster preparation, but also that we can live in a healthier lifestyle to keep the world more ecologically safe and friendly.
It's interesting you bring up about ethics. I was remembering back in class that I was in graduate school, and it was an article we had to do an analysis paper on about Hurricane Katrina and how they had to medevac people out of the hospitals, and how the medical staff was making decisions on they couldn't take everybody, as some people had to stay within the hospital with the limited resources, and some had to be medevaced out. In times of crisis and emergency, those medical ethical issues are really put to the challenge.
Well, as Stephen mentioned before, these are painful decisions and nobody wants to make them. But rather than making them on the spot with inadequate contemplation, it makes more sense to discuss them in advance in the whole community, so the whole community understands and agrees why we're making the choices we're making.
So in terms of, I want to turn a little bit now to funerals. How do you think COVID will threaten the very essence of funerals?
I hardly need to tell you, Jill, and friends at ADEC, but the very essence of funerals is community. It's rituals of community mourning, largely based on touching and eating together. And this even goes back to chimpanzees. COVID is rendering such social gatherings impossible, not only for COVID victims, but for millions of people dying from everything else, because the funeral homes can't allow them at the same rate that they used to. There's no wake, no open casket, no washing the body, no embalming for COVID's people. And this is spilling over into other types of deaths. Viewing and touching the body of the deceased becomes prohibited, as does approaching or touching the body of those deepest in mourning. Now, in Islam and in Japanese Buddhism, to which I subscribe, washing the body by the family is an important religious ritual. But this is ruled out. In Judaism and in Japanese society, friends and family bring food to the mourners who are sitting Shiva. But this is ruled out. And people who want fuller funerals may also be losing the income to pay for them. So both for economic reasons, for sanitary and disinfectant reasons, a whole range of reasons make funerals very different than society has hoped they would be for millennia.
Contagious disease almost goes against everything that we as human beings, in terms of our burials, rites, rituals, things that we know have helped comfort us through our grief and helped us bury our dead. I mean, when anybody in my family has been dying, has been sick, people usually commune, they gather together, they go to someone's house, they make food. Then, then when someone does die, I mean, we always say this, that we should maybe connect with each other more than rather at a funeral. There are too many funerals that you go to and you see all these relatives you haven't seen in a while. But just that receiving line when people come up to you and they'll give you a hug and wish their condolences, and it's almost in a way you're sad but happy to see them at the same time because you haven't seen them in so long, maybe a third or fourth cousin. So all that's really been, it almost as if a contagious disease completely just eliminates that for people.
We're conducting a major nationwide survey on funerals in Japan right now, amid discussion of whether funerals should be abbreviated or extended. And one of our preliminary findings is that if you call out to a wide range of old acquaintances, old friends, second cousins, people you haven't seen in a while, and bring to the funeral, some of them will realize, hey, Carl's a widower, or Jill's a widow now. Why don't I put in a little bit of extra effort to call her up and say, let's go out for lunch or shopping or just get together and chat. And the people who are invited, of the many people who are invited to a funeral, a certain percentage of those will do tremendously good work for helping out the bereaved. And when we're only now allowed to have 5 or 7 or 10 several meters apart in the funeral, the chance for that extended network to physically realize the loneliness or despair of the bereaved closest of kin, that's wiped out. We're losing a valuable grief and bereavement resource.
And I don't want to certainly downplay this or make it to downplay it, the physical distancing, but I have often said throughout this that if this had happened in the 1970s, we wouldn't even have the ability to have a virtual Zoom funeral or to be able to talk to anybody. So in that respect, as much as the physical distance is putting these barriers between us, very fortunate that maybe in a time and day, it's happened during the day of technology where we can do this with each other.
We're thankful for small blessings, and technology is no small blessing. But again, the news and technology that brings us these possibilities also raises the danger of stigmatization. And we have to be sort of aware of that at some level.
Yep. And as you pointed out, also the pervasiveness around the world that's raising the anxiety.
The other thing I would argue is that in the 70s or in the 1370s, plagues led people to do more prayer, more meditation, to do more journaling and diary writing, to do more self-reflective writing, create music and poetry, and communicate, communicate with friends, not only on Zoom. I'm delighted with all that technology makes possible. And our sense that we always have to be somehow electronically connected to somebody is a modern distortion of the nature of human experience, and potentially a fleeing of the need to just sit with ourselves and look inside and see what life is all about, see what really matters to us, and how we can express those values in poetry or music or a letter without electronics.
Mm-hmm. So, Dr. Becker, just in brief today, like as we're kind of ending our segment with, what kind of grief do you think does COVID create, and how can we rise above some of these challenges?
Well, we have a grief not only for sudden death, and COVID is reasonably sudden, unexpected, but also a grief about not being able to bury or memorialize the ones we were close to, and a grief about, sort of anticipatory grief about not knowing where our lives are going next year, not knowing when we'll be able to see each other in person, or if we'll be able to see each other in person. And all of our plans, I mean, my schedule is planned a year in advance, and all those plans are out the door, along with all that income and projected expenditure. So maybe it's overstating to call that grief, but an angst, an uncertainty, an inability to do things as usual forces us to a bit more existential self-introspection, I would hope.
I have to ask this question. It's because you are a scholar and you live in Japan. You know, the question of guilt, you think, I'm going to raise that question only because in some faiths and spirituality, how we prepare our dead for their death and ritualize them sometimes has an effect on the other family member, potentially, in their belief system. How do you think that might play out with COVID?
Did you say guilt?
Yes. Guilt and responsibility. So sometimes in some cultures and faiths, it's the responsibility of the family to do certain rituals around, like you said, the washing of the body.
Yes.
And you know, people in their belief system, maybe like in Viking, let's say in the Vikings time, there was a certain way you had to bury the dead or else they wouldn't go to Valhalla. Or they, you know, if they died a warrior, they got, you know, their sword was laid upon them. And so it really affected their passage into the next life. So how do you think that might play out for people?
Well, both in conservative Judaism, Christianity, and Islam, but also in Buddhism, from conservative to liberal, there are very strong cultural expectations of how mourners should treat the body, how people surrounding the mourners should care for the mourners, and a length of ritual. In Japan, it's 7 days, 21 days, 49 days, the first summer equinox, and so on, where these rituals are built into our society. And if the tsunami of death makes it either numerically impossible or stigmatized to conduct these rituals, certainly the people who were, in a sense, looking forward to performing these things will be deprived of that experience. And even worse, as I said at the beginning, if we give these up temporarily because COVID said we didn't need to or we couldn't do it, there's a danger we'll give up permanently. And then we'll have lost much we learned in the last century about grief and bereavement.
Dr. Carl Becker, thank you for joining us here today, staying up late for us, staying up late to join with us and share your wisdom with us. We very much appreciate it.
Thank you.
Now I'd like to turn to Dr. Andy Ho from Singapore. Hi, Dr. Ho.
Hi, Jill.
Thank you for joining us here today and also staying up late for us. Us here over in the United States who are conducting our talk today. I know you wanted to focus a little bit on your topic, the loss of self and community amongst COVID-19. Can you share with us the experience of Singaporean seniors and youth and the role of governments and the impact of circus breakers measure?
Sure. Well, so first of all, thank you for having me. It's a pleasure to be here. I think living in Singapore for the past couple of years and going through the COVID-19 situation in this community made me realize, you know, that the local government has been doing an excellent job compared to many other governments around the world. it was only back into less than 12 days ago, whereby our numbers of confirmed cases was below 1,000. Ever since the beginning of this, in the end of December to April, we were able to contain the virus in a very well-mannered way. In fact, I think the government has done a lot of good measures, a lot of good preparation initiatives to ensure that people are being safe, people are kept safe. And I think because of this, a lot of our seniors as well as our youth have this sense of false safety, that because the number is so low, nobody is dying, that they feel like this is not going to concern them. And so over the past 12 days or so, when we usually get numbers within maybe 30 to 40 confirmed cases a day, we're now seeing 150. Yesterday was 240 cases every single day. We jumped from 1,000 to 2,583 yesterday within a 12-day time span. And that sense of security or safety, or the false sense of it, had really caused a lot of concern for the government to keep people in place. The Singaporean government does not like the word lockdown. We don't want to lock people down. What we want to do is to put in breakers between the circuits so the loop do not continue, so we call them circuit breaker. And these type of measures have been done incrementally. So in the beginning, we started to say that there's no need for you to go outside, just stay at home. You can still go and exercise, do your chores and do your shopping. But progressively, people are still meeting up in groups, in large groups, and within the span of, I think, 5 or 6 days, we went from being able to go out to do exercise and to meet up to now we are fine if we are fine congregating in large groups. There's no warning. Once you're taught, you are fine immediately on the spot. So that's actually a good thing. But I can see the challenge of that. Why is that the case? Is because for a lot of our seniors in Singapore, although they do live with their family, the relationship with their family may not be very strong, or they already have a strained relationship. And therefore, for them, their sense of community and individuality really based on the neighborhood that they have. So in Singapore, what's unique about them is over 70% of our population actually live in public housing. And public housing estates are large communities and neighborhoods that has food courts, that has places that people can meet, people can sit around and gather and chat. And the common practice is in the morning, it's mostly the seniors, ladies who come together, do their shopping and meet each other and congregate. At the evening time with the men who come together and sit around, have beer, and that type of relationship really gives them a sense of connectedness, a sense of personhood, a sense of identity. And once you remove that from them, we are seeing that now amongst all the 3 tiers of population, your young population, your middle age, and as well as your seniors, it is the seniors that are not really conforming to a lot of these circuit breaker measures. And it's really a reason for concern. In terms of the youth, from my university at least, I think there is this false sense of security because the numbers are low, and students really, they also derive the sense of identity from the community that they have and the friends. And so in the beginning of circuit breakers, they're still conjugating and meeting a lot. But now we see that I think the youth are realizing the urgency and gravity of the situation, and therefore they're distancing themselves quite well. And we're using technology in many different ways to keep connection. But it becomes quite hard for the seniors to do that because they're not tech savvy. And to get them to go on Zoom, it's probably going to be harder than anything else, I would imagine. So that's sort of the difficulty that we see in Singapore.
It's interesting you bring up this there's this disparities here between seniors and youths. I think this is a phenomenon that's actually can be happening kind of globally. I can just even share an experience. I had at the supermarket yesterday going my weekly food shopping. I looked like I was going into a containment zone. And there was a woman probably in her 80s there who had no gloves, no mask, was wiping her face, was touching everything she could. And then some younger people who are doing the same. It seems like those in the middle years are sort of following some of, I'm not saying everybody, but it's interesting that that is also sort of reported a little bit throughout the world, the issues with, youth going to beaches or not taking this serious. Mm-hmm. And you're saying you think that's happening in Singapore, again, for what reason?
I think one of the major reasons is we built a lot of our sense of identity throughout the relationship that we have in our lives. And You know, for our family, it gives us a sense of belonging and safety. For our work and our colleagues, it gives us a sense of competence and knowing that we can achieve something in our lives. And within our friends, it gives us a sense of community. And when we're not able to be in these connections, we're not able to find ourselves in a relationship, we try often to bend the rules to see what we can do and what type of boundaries can we cross in order for us to feel like ourselves again. I think technology can play a huge role in supporting younger people to find a sense of connection, because we're much more able to maneuver the web and different applications that we can use. But it's a lot more difficult for seniors. In fact, I was talking to a newspaper the other day, and I was wondering, you know, I was talking to them, one way to perhaps incorporate technologies into seniors' lives is to make it more simple. I mean, you know, back in the days when we have cell phones, it's only the purpose of it is to talk, right, to make a phone call. Now we have smartphones that we have hundreds of apps in the cell phone, that when a senior pick up a cell phone, they would have no idea how to get to Zoom or get to whatever apps they need to go to. And I think what one thing could help is to make simpler, user-friendly technology that caters to a population that doesn't need all these other extra things, but just simply give me a phone with an app that connects me with my family. You know, those are things I can potentially see happening and would be useful for a senior population.
It's so interesting. I have an elderly client, and she's also she's low income, and she has a severe mental illness, and you know, she doesn't have access to a computer nor the HIPAA control portal that I use to do my telemental health. But she's got FaceTime. She can push that one button and get to FaceTime and knows how to do it. Normally, not under normal circumstances, wouldn't use that. But as Dr. Connor was talking about, you know, not everybody has access to finances or has access to technology. And you raise a great point about how also some of our technology systems are way too complex for people to figure out and understand at sometimes any age, but particularly for our seniors, maybe.
Mm-hmm. Mm-hmm. I think apart from technology, I think even although right now we are very much in a circuit breaker or social distancing measure, but we are still in Singapore allowing seniors to go out or people to go out to buy food, because in Singapore, the culture is people rarely cook at home because the markets are very cheap, they're affordable, and the food is good. And so we're still keeping these hawker centers, you know, these food store centers open. And people can still very much go there, and they have to line up for sure and to keep, you know, 2-meter distance between each other. But during those times, perhaps people can still, you know, feel connected to other people. When they purchase food from a food store owner, the owner can, you know, provide that sense of compassion and empathy and to just check up on them. That sense of compassionate citizenship and neighborhood can really potentially play a huge role in supporting our seniors through this sense of isolation and loneliness in COVID-19.
So trying to keep that sense of community when community needs to circuit break a little bit, but also trying to keep that sense of community. I like how you use the word circuit breaker, and you really define the difference between lockdown. Because our language has a lot of meaning, and saying things like lockdown to people sounds what? It sounds so, it sounds punitive, it sounds punishing, it sounds confining. So circuit breaker is a little bit more of empowering, to the sense that we're wanting to try to break the disease, but people still are able to commune a little bit and follow the guidelines. Because language is so.
Yeah, I think I agree with you completely, and I think the Singaporean government is very careful in terms of the words that they use, because although people would think that we don't have much of a democracy here, but democracy is perceived differently in this part of the world. But the Singaporean government do really care about how the people look at them and how they perceive them, and therefore every word, every term that they use are carefully thought of. And again, yes, using the word lockdown can seem very punishing and negative for people. But to put in a different light and to say that the government is offering all of these measures to protect you, and we're doing this incrementally, and if you are able to, you know, to live by these measures, then we'll not put more measures on you. And that's what our Prime Minister has come out and say is if you follow all these things, potentially you can get out of this quite quickly. But if you don't, we'll put on more restrictive measures for you. So that type of governance, I think it's pretty well appreciated from the local population.
I know here that, using the word shelter in place was very important in the United States, because sheltering means a little bit different than being in some sort of lockdown, or it means that you shelter in place, all those guidelines you just said, that people aren't here on house arrest. But yes, if we need to go to that for the public safety, we will, but giving people the ability to kind of, it's more of a safety measure than anything else.
Mm-hmm. For sure. Giving people that sense of empowerment and letting them know that they are still very much in control of their lives, and they already, they can determine how this will unfold by their own behaviors. I think that's a type of mentality that we can use to empower people.
Dr. Ho, anything else you'd like to share with us before?
I think one thing that I may want to raise here in response to what Kyle talked about earlier about in terms of the different types of social justice that we need to look at. And I agree to all the things that Kyle has talked about, but being a person who originally was, well, my family's in Hong Kong, and knowing the virus, the origin of the virus, and how this is being played out into the international political stage, I think there is a lot of grief in people's mindset, especially people in Hong Kong who, as you know, are fighting a democracy protest. And in the midst of all of this, COVID-19 has happened, and it leads to a lot of political grief. It leads to a lot of disenfranchised grief for people who are not only politically are being silenced, but also feeling they're even more silenced now because they can't go out and they're in social distance measure. I think while I certainly agree that in this time of crisis we need to work together and collaborate and find a solution to the ordeal that we're facing, but eventually, as we hopefully can rise out of this, we need to have accountability to look at the whole situation and to see, where the fault lies, and who should be held accountable for this global pandemic. But I think that's something we need to think about and ponder as we progress through this situation.
Very powerful. Thank you, Dr. Ho.
Thank you, Joe.
And stay safe. Be well.
You too.
With that, I'd like to turn to Dr. Darcy Harris, coming to us from London, Ontario, Canada. Hi, Dr. Harris.
Hi, hello everybody. So it's been interesting to hear the perspectives of my colleagues here and to be thinking as each of you shared different aspects of your regions and how your regions are approaching this crisis. I think I'll start off by saying that a lot of people confuse that Canada is kind of an extension of the United States, and that is not true. That even though we have quite a bit of proximity to the United States, things here are quite different, but we're affected profoundly. I looked at the statistic, I think 90% of the Canadian population resides within 100 miles of the United States border. So even though as soon as you cross the border, you are crossing into another country with a whole different political system and healthcare system, we're profoundly affected by our neighbors to the south. Where I am right now in London, Ontario, is between Detroit and Toronto in this little isthmus of land. And right now, Detroit is a major hotspot for infection for the COVID-19. New York, which borders on another side of Ontario, is also another hotspot. And our borders are currently closed except for very essential travel. And there's great fear right now that the borders will reopen prematurely and that we'll have an influx of people coming in who are either infected or don't know it, or just for the sake of the coming across the border freely again, we will start having an increase. Our current rates right now, we're at 24,000, a little bit more cases. We've had 700, a little bit more than that, deaths. It's certainly been better than other places in our region, which we're very grateful for. There's probably different reasons for that. And we're starting to see the flattening of the curve, which is a relief. I'm hoping that lasts. Every day at 11 o'clock in the morning, we have a briefing on the television from our Prime Minister. And it's an open briefing that people are able to call in and speak directly with their questions. It's been interesting to get a smattering from across the country of some of the concerns and where people are raising their concerns. Certainly the big concerns here are economic as well. I heard several other people talk about the impact. And I think, Chris, you mentioned the sustainability. We have huge governmental initiatives right now to help businesses, especially small businesses, and now people who are self-employed who can't work because their businesses or their places of work are closed down. All of our restaurants are closed down. Most places of businesses, unless you're considered an essential business, you are not allowed to open or go to work. And so they've initiated a Canadian emergency relief package that people can access. They get payment within 2 or 3 days, which has been helpful. The big concern, obviously, as Chris mentioned, is the sustainability of being able to do this over a longer period of time. But for now, people are able to get their necessities, and there's not fear at this point in terms of day by day. I think a lot of people are looking at the long-term financial impact. I'm hearing from many people, we'll never recover. I think we will. I think it's just going to be a very long recovery period. So like some of the other countries, we're having problems with personal protective equipment with our healthcare workers. It's been heartening in that people in the country have come together. Ontario has been hardest hit, mostly because of proximity. Toronto's our biggest city, our biggest international city. We had people traveling into Toronto before there was an awareness of how significant the crisis was. And because we're surrounded by major cities in the United States as well with other traffic. So Ontario, our province, has been hit the hardest. And we've had a real shortage of availability to get to professional protective equipment. And I noticed Alberta stepping up and having extra. So there's been now kind of a countrywide awareness of, okay, you guys need this, we'll pass that along. I think it's disappointing that last week we were aware that in the United States there was a clampdown on the export of personal protective equipment that was earmarked for Canada. I think our Prime Minister handled that quite well by saying, we're not going to address that right now. We're just going to focus on what we can and to try not to make this become about us versus them. So I was pleased to see that happening as well. I think some of the other issues that we're facing now are our long-term care facilities, and that I think in British Columbia, because of the proximity to Washington, there was a long-term care facility that was impacted very early there, and it transferred up because of the proximity in our border. That's now quite contained in British Columbia, but Ontario, we're having issues now of long-term care facilities facing one person walks in the door, and this is a group of very vulnerable people, and one person walks in the door, and the people who get infected who are in long-term care are very vulnerable. And so this has been a very big issue for us, and trying to decide how to contain within these areas. Seniors are, as we've talked about with several other people, are at risk because of the tendency for the COVID-19 virus to be particularly virulent with this population, but they're also very at risk for social isolation and the effects of social isolation as well. My father is in a senior's home. It's not long-term care, but it's a senior's home. They've all been told they have to stay in their rooms. They're eating meals alone. They're not allowed to socialize, and that's gone on now for over 3 weeks. You can imagine for people who are isolated, who don't have access to the technology, and what that's doing for them and to them. So I think those are issues that now we're trying to address, and to see how we can do outreach to groups of people who either don't have access to technology in our rural areas, or people who do have access but don't know how to use it. So I think that's another issue as well. One of the big issues here is the converting, obviously, of everything online. I'm an educator. Several of the other people who are on the call are educators. We all of a sudden had to convert every single one of our classes at the university to online. We were fortunate in our program that we already had a fully online program, so it didn't make a huge impact for us, but certainly in our university, we were one of the only programs that had a fully online capability. So the faculty in my program have been very busy, not just with our own students and what they're trying to get through in terms of finishing out the term, but to other university programs who have not done this before and who are unfamiliar with that. We've sent all the students home. Our campuses are all closed. Some of the students went home and they don't have access to the internet the way they would at school. There's distractions. We have a lot of adult learners who have children at home. They're homeschooling now. One of my adult learner students, we have several in our program, has 4 kids. And so she starts her classwork for her university work at 11 o'clock at night after she's finished day schooling the kids, finished cleaning up around the house, and everything is quiet. And that's when she does her coursework, is from 11 o'clock at night till 2 or 3 in the morning. And then she's up again at 7 trying to manage the kids. So it's things like this that we would never have thought about that are having a huge impact on just people's daily lives. Most of my colleagues who have counseling practices have converted to online. They're very busy. So it's not like people said, well, I can't come see you now, so I'll wait. People are feeling an intensification of their pre-existing trauma. The grief responses that they had from losses of loved ones or their own losses before have been intensified by this time, the degree of uncertainty. So we've had actually most of my colleagues who are in clinical practice they're very busy right now, and they're very busy with online work, which is hard. It's tiring work and difficult work, I think, as well. The good thing about the online capacity for us is that most of our communities have developed community Facebook pages. So my city, London, we have a London, Ontario care group, and people will post on there that maybe they've been quarantined so they can't get out. Can someone pick up groceries? Asking if people have access to different things. A lot of the doctor's offices for regular care are closed right now, so people who can't get into their primary care providers and don't want to go into urgent care, maybe for prescription renewals or for minor issues, they're referring people to different virtual health clinics, telehealth, and this site has been a wonderful wealth of information for people. You just put it out there and you've got a whole community of people gathering around to answer your questions or to put their resources together to help out. So that's been really lovely to see. I think a couple of people mentioned that they've seen communities coming together, and that's been very heartening for us as well. Our student community is doing the same thing. So, you know, Zoom has become a lifeline for many of us. And I think Facebook has been also a lifeline for many people as well. My daughter's a teenager, you know, she's stuck at home. She can't go to school. She's got a boyfriend she hasn't seen now for almost a month, but she could at least FaceTime him, and they have regular contact, as do all of their friends. And I'm grateful that they have that ability and to talk and share amongst each other. I think a couple people also have mentioned the idea of non-death losses, and of course, most of you know this is my area of interest, but it's just such a spectrum of losses. And what I'm also seeing is people disenfranchising themselves or self-disenfranchising that, well, at least it's not a death loss. You know, we had to cancel our convocation for our students, and most of them took it in stride, saying, we understand. Privately, several would say to me, this was something I felt was a life milestone for me. You know, I was looking forward to it. My family had already made plans. You know, I was going to cross that stage and get my degree, and now I'm not going to have that. But in the big scheme of things, I feel like that's so minor. But really, if you compare grief, we all know you don't compare grief, and this is real grief. You know, another thing, my daughter came up to me, she ordered her prom dress, right? This is grade, you know, grade 12, her prom, beautiful dress. And she got it out of the closet the other day and she said, I'll never wear this. And I said, you'll find a way to do it, but it won't be the way you had thought. And so there's losses like this that people often don't want to mention because to them, I'm not dying, I'm not, you know, I'm not dealing with the life and death stuff, but they're starting to mount up with a lot of people, I think. So I think it's a combination of the anxiety of, you know, what are we going to be facing? I think the economic uncertainty has been a big issue for a lot of people, you know, not being able to work, how are we going to get past all of this? And then, you know, the loss of connection, the loss of just daily life, the ability to live your life. And to be able to speak about that, and then to also look at the bigger issues of, you know, the number of deaths and the infections and the frontline workers who are really struggling. Ontario sent out a call for anybody who has skills to please register with the province. So those of us, I'm still a registered nurse, although I'm involved in higher education, I would be registering to see if they really needed a call out for people with skills and expertise, that they could call upon us if it was needed. So that's kind of our cap of where we are in Canada at this point.
Darcy, thank you. Thank you so much. I mean, with everyone shared, you know, it sounds like there's a lot of commonality versus difference in what's going on in all of our countries. You know, here in the United States, we're facing an unemployment crisis, not the health crisis that's caused an unemployment crisis. You know, people are concerned about the economic return, what that means. People aren't commuting, restaurants are closed, small businesses are closed. I think I shared with you, Darcy, you were talking a little bit about small businesses. As a mental health provider, my business has increased threefold, which has been exhausting for us mental health care workers. But in my family, my aunt owns a travel agency and they are pretty much devastated at this point. So the travel and tourism industry and small businesses, PPE, we have, you know, here we're having issues with that too. And people are sewing. And like you said, Canada so much borders the United States. I am from New York, if people don't know that, even though I'm here in the DC area. And New York just blindsided by this whole thing. And we've got healthcare workers that are in my family. We've had some COVID deaths and people are exhausted. They're coming home, they're taking care of families. We have family members that are nurses that are tending to dying patients every day, or patients they were taking care of that they don't want to get COVID in the hospital. So, you know, in our youth too, are seeing these losses of rites of passage, which you don't certainly, it's great they're reframing them, but then they're almost feeling bad for having them. So a lot of commonalities that everybody has shared and some differences, how this is all affecting us. So I'd like to just kind of open up the floor now and see if you all have any questions for each other before we conclude today. Anyone? Or did everybody just say it all?
I'll add in that, you know, Andy, you've made an interesting comment about the government of Singapore. And I think, you know, the ability for some governments to be able to, how should I say, restrict freedoms of people in their countries for the sake of public health. I think that's had a huge impact on globally. The countries that are able to initiate these types of restrictions for the sake of everybody staying healthy, you can look and see those are the countries that are flattening the curve, and those are the countries that are containing better. It's a real tension between what is public responsibility versus personal autonomy. And you can see how this is playing out globally. In Ontario, we now have, and I think it might be across Canada, we actually do now have a report line that you can call and report if you need intervention. Let's say a group of young people are hanging out in the park across the street, and that's not allowed. Rather than you going out or risking yourself, that you now can call report lines, which is, it's this big brother kind of feeling, but it's necessary, and people are taking it seriously. And so I think this is really an important aspect. I would never have considered the differences in countries and governments and the impact this particular aspect of this outbreak has had globally on us.
I as someone who experienced multiple democratic systems in different countries, I feel I appreciate what the Singaporean government has been doing and can do because of their legal structure, as well as the way that they can monitor and track people's movement. In a way that the Singaporean people has grown accustomed to it. For example, if you want to drive a car in Singapore, you would have a device that is attached to your car, and basically wherever you go, whichever parkade you go, there's records of where you've been. So, but in exchange for that type of privacy and freedom is that you're very much protected in a very safe society. I do not disagree with that. I think originally when I came to Singapore and I had to face that, I was like, I'm not so sure about that. But now I've been here for 5 years, I feel like it's actually a good thing. But at the same time, when a government has that type of control on its people, it's a really fine line in terms of how they will exercise it or abuse it. It depends on the regime of government and what their intentionality is and how they define democracy. So it's a difficult question. But at the end of the day, I feel like although I'm a Canadian, I feel like right now I'm glad to be in Singapore.
Right. So the fine line between who's controlling the information and how much information on your private life. So, but I think that this is a call to arms to public responsibility, individual, like I think Carl had mentioned before, individual responsibility for the collective good, that people, are following the guidelines that they've been given, is making an impact on public health. And that's sometimes a hard switch to make in your head, for people not to be able to commune or go on spring break while this contagion was happening. So I think that's something important that you bring up. And I think if people aren't seriously getting the message now, then it's going to be a really long and difficult road.
Yeah, I think one thing that I want to add to this is I talked to a reporter the other day, and she was asking me about, we're putting all these measures for circuit breakers, and if you break the law, you get fined. And she was saying, do you think with fine system in place, people would do the right thing? And I would say, well, yeah, probably, but that's not what we want to see. We want people to be responsible citizens. Rather than being afraid to get fined, you want to do this because you're caring towards your neighbors and your fellow human beings.
Great point.
In Japan, everyone carries medical ID showing they have tested positive and therefore have antibodies to polio, TB, and other dangerous diseases. And there's talk now of having a COVID positive card or identity of some sort for people who have been through it and now carry the antibody. And people who carry the antibody could both provide the antibody as a serum to help those who haven't yet developed antibodies, and they could also be on the front lines of conducting new opening businesses because they're unlikely, from what we know at the present time, to reinfect with the same virus. But I'm wondering what other health professionals, maybe like Stephen, would think about the notion of I've been through it kind of passport.
I don't know if we have the data on that yet.
I think it's too soon to know. We're hearing too many reports about people becoming reinfected who don't have immunity.
Most of those have proven to be inadequate testing.
Inadequate testing, yeah.
Because there's a lot of false negatives. You can have the best equipment in the world, But if you fail to get the right sample of mucus, you're not going to detect that it's there. And most of the people who are supposedly reinfected, on careful inspection, one of the false negatives in between just hadn't picked up the right mucus. So there are testing issues. But we all also can test for the antibody. And if somebody has both tested negative and has a large population of antibodies, there's a strong probability they're not going to be reinfected and that their antibodies could be helpful for others.
And my mind is kind of conjuring up, I don't know, I feel how anyone else feels, but conjuring up this whole idea of marking people, the fine line between safety and stigmatization. You know, say back during the HIV/AIDS epidemic, all of a sudden people now have to be labeled with having a disease. It's really strongly bringing up these, for me, images of, being marked or tattooed or having to carry a card. So, stigmatizing in a way those that.
In Japan, it's a good thing to carry an immunity card, whether it's for TB or polio or whatever disease you're now immune to.
What if you don't have an immunity card? Where does that put you?
Well, most of the population in the world doesn't yet have COVID immunity cards.
Right.
But who are we going to send back to work first?
I think one of the issues is this is not a sprint, it's a marathon. And we're still in the very early stages of this pandemic. And, titrating that health and economic question, I think, is going to be, a significant and profound challenge. And I think there are lots of impacts that we've not even considered yet. When we're looking about the health impacts of people, not in a sense, many not receiving human touch for potentially months and months. The profound impacts of social isolation. In a sense, it's still a novel experience when we're talking 3-4 weeks, but our government's talking about timeframes of 6 months, of even longer periods of frames of reference. So I think this will be a dynamic unfolding, and I think it will unfold in ways that will be both surprising and challenging.
Well, on that note, I think that I'd like to thank you all. I know some of you, it's very, very late, and for some of us, it's a little bit early. I want to thank you all for joining us here today at ADEC in Conversation. You've really provided a lot of robust conversation on this international perspective of COVID-19. I wish we didn't have to have this conversation, but now that we do, I'm very glad that all of you have been able to provide us the time and the opportunity to talk to you from around the world. So for all of you, thank you again. Be well, be safe. I hope you practice all the physical distancing measures that your countries and provinces and counties and communities are instructing. And to our audience who's listening, stay safe and stay well. And thank you for joining us at ADEC in Conversation. Take care, everybody.